So I would like to welcome one of our esteemed board members who is going to do our formal opening for this evening. And could I please ask James Gray to come forward and do a formal opening for us. Thank you, James.
E ngā manuhiri, tēnā koutou. Nau mai haere mai ki AMRF Lecture Series 2. Whakatau mai ki runga i a mātou. He mihi tēnei ki ngā kai tautoko o tēnei kaupapa ko Aotearoa University, ko Auckland University, me JMI Wealth, kia ora koutou katoa. Ngā mihi nui ki ngā kai kōrero o te pō, Dr. Rosemary Frey, Associate Professor Gary Cheung, me Professor John Windsor, nau mai. Ka huri atu te mihi ki a AMRF. Ngā kai whakahaere tēnei hui mō te rātou manaaki me te tautoko. Kei te mihi tuatahi te mātou nui o te rangi nāna ngei mea kātua. Tēnei te mihi kia koutou, ka nui te koa me te hari ki tūtaki i a koutou i te kaupapa. Nō reira, ngā mihi nui kia koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. For those who don't know me, yes, I'm a trustee on the Auckland Medical Research Foundation. My name is James Gray, and on behalf of AMRF staff and the board, I'd like to welcome you all here this evening for our second lecture of the series. I'd also like to thank some of our sponsors, AUT, Auckland University and JMI Wealth. Small caveat, I also work for JMI Wealth, but thank you for their support. We'd also like to welcome our speakers tonight, Dr. Rosemary Frey, Associate Professor Gary Cheung and Professor John Windsor. Welcome to our lecture tonight. Also like to thank AMRF, our staff, for putting this together tonight. Looking forward to hearing hearing the speakers tonight, and as you are all here in person and online as well. So yeah, I'd just like to welcome everyone here tonight, and I hope you enjoy this evening. Thank you.
Well, thank you, James, for such a wonderful wonderful welcome and introduction. And I'd also like to warmly welcome you all here tonight. Thank you for coming out on a chilly night, braving the traffic. At least it's a lovely, fine night, so I'm glad you could all find your way here. So, as I introduced myself before, Sue Brewster, Executive Director of Auckland Medical Research Foundation, and this is the second in our 70th anniversary celebration speaker series. So, and we're also here tonight celebrating the awarding over $100 million of medical research funding. So there's a lot to celebrate. Like James, I would like to thank our 70th anniversary partners, who are JMI Wealth, represented by James Gray here tonight. I'd also like to thank the Auckland University of Technology, represented here by Brett Cohen, and also the University of Auckland, and we have Mark here tonight representing as well in place of Frank Bloomfield. So thank you to your partners. You've made a lot possible to happen this year, and you are the ones also for AUT and for UOA doing the research, so that's fantastic. And obviously JMI Wealth are helping us bring in the dollars. And I'll just introduce Associate Professor Gary Cheung as well. So Gary is an academic old age psychiatrist who has a joint appointment at the University of Auckland and Health New Zealand. He is a Fellow of Royal Australian and New Zealand College of Psychiatrists and is currently the Chair of the Subcommittee of Advanced Training in Psychiatry Old Age. He co-leads the research and implementation of cognitive stimulation therapy in New Zealand. In 2021, Gary was appointed by the Director General of Health as a member of the Ministry's Support and Consultation for End of Life in New Zealand group, a statutory body for New Zealand's assisted dying service. Gary's presentation tonight will touch on aspects of his older adult health research and look at how his research is increasing the understanding of often complex factors influencing the person's journey of requesting and receiving assisted dying. So obviously with both topics being palliative care and assisted dying, there can be some sensitive material in these presentations, so I just wanted to make you all aware of that. And hopefully you all came expecting these topics to be covered.
Kia ora koutou, ko Gary Cheung toko ingoa. This is a very serious topic, so in the next 20 minutes or so I'm going to summarize our research on the use of assisted dying in New Zealand. So assisted dying been legalized in New Zealand for the last 3.5 years. It was the 7th of November 2021 when it was implemented. I remember that day because that was my brother's birthday, 7th of November. And this is a serious topic, but because AMRF has funded our study, so I'm here to talk about our study. Just a little bit about myself. I'm an old age psychiatrist. So I specialize in the mental health of older people. I have my week is very interesting. Mondays and Tuesdays are my clinical days, so I see older people with mental health issues and dementia in an outpatient setting. Wednesday, Thursday are my teaching days and some postgraduate supervision, and Friday usually my research day. But I'm taking an annual leave tomorrow for good reason. I'll tell you later. So that's my teaching research. Assisted dying actually is a very small part of my research. A lot of my research is with dementia and particular psychosocial aspects of dementia, how to improve the quality of life of people with dementia. And service to community. I'm a Chinese, born in Hong Kong, came here as a teenager. And we know dementia services for the Chinese community is really lacking. So some of my time is giving back to my community to improve information resources for Chinese with dementia. So I think, Sue, you mentioned I was a SKINS member, so I need to declare that for the first 2 years of the legalization of assisted dying. I'm a rare breed, actually. I'm a life suicide prevention researcher, but also assisted dying researcher. So not many of us actually in New Zealand are doing both research. It was about a decade ago, I was doing my doctoral thesis that was on suicide prevention in older people. And part of my research was reading coroner's report of older people who died by suicide. I read many suicide notes, and some of them, actually 10% of older adults completed suicide had a terminal illness. So 10%. And when I read their suicide notes, I was in tears. Yes, I'm a psychiatrist. I usually can hold my emotion. But the suicide note talk about the suffering they have, the lack of functioning, lack of independence, and they choose to take their own life. For me, it's a very strong message. I have to declare I am neutral in terms of, well, maybe a little bit over neutral in terms of supporting assisted dying. I see that as an option for people. Not everyone's option. For some people, they may want that as an option. So that's how I got involved in the assisted dying research. It's actually from my suicide prevention research. I don't do a great deal of suicide prevention research now. Having said that, I just have a project with my colleagues in Australia looking at adapting their education tool for gatekeeper, looking after older people so they can recognize the sign of older people at risk of suicide. So there's the funding from the Office for Seniors, so we will complete that in the next few months. So this was 2020. Did you vote at the referendum? Some of you. Anyway, 66% of New Zealand voted yes for assisted dying, the End-of-Life Choice Act 2019. And this is the eligibility criteria. So I'll go through this with you. So to be eligible for applying for assisted dying, you have to be over 18, you have to be a New Zealand citizen or permanent resident. Suffer from a terminal illness that is likely to end your life in 6 months. Now, how good are we in prognosis? So some of the research are telling us why 6 months. Certainly in some states in Australia, they are 12 months. In Canada, they are 12 months. And in fact, in Canada, there's no limit in terms of the life expectancy. So the person also needs to be in an advanced state in irreversible decline in their physical capability. Unbearable suffering. How do we measure suffering? It's a complex construct, actually. I said I'm suffering, who's going to argue with me? So, of course, there's physical suffering, but it's also psychological suffering, existential suffering. In fact, when you look at the literature from Canada, existential suffering is one of the top ones in terms of the reason people wanting assisted dying there. Well, the last eligibility criteria is the most important. The person has to be competent or has capacity at the time of requesting assisted dying, also at the time of medication administration. And as a psychiatrist looking after older people, that is my specialty, capacity assessment. So that sort of brings some of my interest in this area as well, because we know it's difficult to assess capacity in general, and doctors have told us that a lot of time, and that's been confirmed in research. Capacity often have poor inter-rater reliability. So I may say this person is competent or has capacity, and that doctor come to assess the person may say the otherwise. And the literature has been telling us the inter-rater reliability is not that good. And this is a serious issue, isn't it? Assisted dying. These are the latest figures from the last 2 years. These are the numbers of people who apply to have assisted dying. What can you see here? It's going up, isn't it? There's more and more people requesting assisted dying. And so in the last financial years, over 800 people applied. Not everyone ended up having assisted dying. Majority was Pākehā, very small percent, 4%, so Māori, just under half of female. Majority was 65 years of older, so that's my work, older people. About 3/4 receiving palliative care at the time of the application, and not surprising, about 70% have a diagnosis of cancer. So these numbers, these figures are fairly similar compared to other international jurisdictions. Okay, I'll go back to here. Do anyone know how many deaths per year? Well, Rose probably know. How many deaths in a year in New Zealand? More than 20,000. So it's between 37 to 38,000. Actually, I asked ChatGPT on the way here. Someone talked about AI, but I remember reading. I can't remember. So it's a 30 something, but then I checked. It's 37 to 38. About 1% of people who died in New Zealand had assisted dying. So the number, if you do the maths, is about 370 cases of assisted dying per year at the moment. So just 1%. Canada, they have assisted dying longer than us. Do you think it's higher or lower? Higher, 4%.
It's cold.
It's cold, yes. Very cold, yes. I've never been there in winter. I like the summer, but never been there in winter. Victoria, Australia. Are you higher, do you think? It's actually a little bit, they're just under 1%. I don't know.
It's warmer.
No, not in Melbourne. That's colder than us. Now, one of the things I learned from our Australian colleagues is in New Zealand, assisted dying is free. It's a free service provided by Te Whatu Ora. In Australia, people have to pay their GP to have that. I actually don't know the funding that well, but I know they have to. Some people have to pay to request and then have the assessment. I don't know if that's the reason, but as I was driving here, I thought, well, that could be a reason. You might think of other reasons as well, like the temperature. So, okay. So this is our research. That's the research team. So because such a serious topic, I got a lot of my psychiatrist colleagues to be part of the team. So the team was formed between School of Medicine, Psychological Medicine, and School of Nursing. Rosemary lead the School of Nursing team. I highlighted Ida. Ida's actually in the audience. I didn't highlight your name because you were coming. I was doing that anyway. But Ida emailed me. I put in my slides, I think Monday afternoon, wasn't it? I think Ida, you emailed me later. And the reason is Ida finished her PhD with Philippa Malpas, ethicist in our department, just before we got the grant, like 6 months or so. And Ida's PhD was how to safeguard assisted dying in people living with dementia. So when we got the grant, you were one of the first persons we found. Ida, would you like to work with us? So Ida spent 2 years with us as a research fellow conducting this study. So Rosemary and I are very grateful because without you, we couldn't have completed this study. We can have the funding, but we wouldn't have the people to complete it. So thank you. So it's a 2-year study. The first year, we look at the Ministry of Health Workforce Surveys. So prior to the implementation of the Assisted Dying Act, the ministry have done some workforce survey. They did 2 cycles of it, and we analysed that. Well, I'm not going to talk too much about that because it's all numbers that can be a little bit boring this time of the day. But in the first year, we interview, when I say we, not me, Ida did, interview practitioners who were involved in assessing people for assisted dying. And these practitioners have no experience prior to that point. Having said that, there may be some, I think at least one person have done assisted dying in Canada and returned to New Zealand to work as a GP, and some of his work involved assessment for assisted dying. So that was the first year, and then the second year, interview partner and families. So that was a 2-year grant. So this is the, so Ida interviewed quite a lot of people, 22 practitioners directly involved with providing assisted dying assessment and service as well. Also talked to a group of practitioners who were not directly involved, like palliative care specialists, but they may have patients that have gone through that process, because we want to hear their perspectives as well. And later on, about a year later, I have a registrar. I was teaching this topic, and he was very interested in how assisted dying practitioners go about assessing depression in people requesting assisted dying. So Eric, I said, oh, yep, if you want to, we can add you into the project. So he also interviewed separately 10 people, and I'll show you some of the results of his result, which is quite important. And we're going to talk to the Ministry of Health, Te Whatu Ora, next in a couple of weeks about the result as well. So you're one of the first people to hear it. And we also talked to whānau family, Maori and non-Maori. For non-Maori, Ida did the interview. Maori, we're very lucky. We have Dr. Tess Moki Meswell, also involved with Roseberry's other research, did the interview for Maori as well. So these are some of the issues that came up when Ida talked to practitioners involved in delivering these services. There's the conscientious objection. So as a health professional, I can declare conscientious objection. So I don't need to be involved, but I need to declare that upfront. And if a person comes to me and requesting assisted dying, and I'm a conscientious objector, I need to direct the person to seek help elsewhere. I can't just ignore that person. But that actually happened a bit in reality. Some practitioner didn't want to know and didn't direct the people to other resources. Prohibition to raise assisted dying. So as a health practitioner, we are not allowed to raise assisted dying with the persons. Even the person have a terminal illness, I can't say, would you consider having assisted dying? Can't do that, but I'll be in trouble. I'll be behind bar probably. We can't raise it. And that is an issue, because if you don't raise it, people don't know about this as an option. And that comes out a lot when we interview the family, that how to go about finding information. Having said that, the ministry and Te Whatu Ora have really good resources on the internet, but not everyone goes to the internet. So finding out the information, certainly overseas, certainly in Australia, some states, practitioner can raise the topic of assisted dying with the person as an option. And I guess some people might want to know all the options, don't they? Yes, we have palliative care. Yes, that's an option. At the moment, we can't raise assisted dying as an option. We are too frightened even to put pamphlets in the office. So that's a bit of a grey area there. Eligibility criteria, I showed you the eligibility criteria before, and I've already mentioned, how do you measure suffering? There's no blood test for suffering. It's all come down to your examination and history. The prognosis of 6 months, how good are we in determining that? Setting a date can be difficult, so the person has to set a date, and sometimes the person died before the day of the chosen day. And the practitioner told us administering medication is quite, sometimes can be quite tricky, because people with terminal illness, they don't have very good veins, and you need IV access for that. So these are some of the issues that came up in our research. We've written up the research. Yes, it's acceptable publication, isn't it? Yep. So at some stage we can share that with AMRF. If you're interested, you can have a read of the full report of that. And that's a really good resource, actually. If I'm a new practitioner, I've never done assisted dying before, I would go to read that report, because it's telling me everything, all the details, what happens. We have a lot of quotes from the practitioner. I'm not going to show you this one. We also talk to people who are not directly involved, the practitioner. So these are like palliative care, physicians and GPs, but their patients chosen to have assisted dying. They're telling us that we need better interface between palliative care and assisted dying services. At the moment, there are 2 separate services. There's no overlap. And people are telling us, oh, we need, palliative care specialists say, we need to learn something about assisted dying. And they're also saying, oh, assisted dying practitioners need to learn something about palliative care. So there's a lot of cross-pollination, and we need to do a bit more of this. And that flow on to the education that's between those 2 specialties. This is quite important finding. So my registrar, Eric, talked to 10 practitioners and asked them, how do you go about assessing depression? Because we know, well, as a suicide researcher, we know people wanting to die have high rates of depression. And the literature have told us that people requesting assisted dying, a high proportion of them actually have depression. So assessing depression is actually quite important. Now, how do we treat depression in the terminal ill is a different topic, because there are limited treatment, and also the life expectancy and so on. But if someone requesting assisted dying and have depression, that can skew their view of the world. So Eric asked them, how do you go about? And the practitioner told us, well, it's a minor concern really, it's not that important. That's what they're telling us. They don't have a formal approach to assess depression. As a psychiatrist, our approach of assessing depression is very structured and methodical. These are the symptoms we need to check. If you score so many of these symptoms, we can make a diagnosis of depression. But the practitioner is saying it's very informal, they don't follow that structure. The third point, they say yes, and we agree with that. There's a lot of overlap between depression and people with the terminal illness. Of course, people with the terminal illness, they're not going to jump for joy. But actually, it's quite difficult as a psychiatrist to differentiate between is it depression in terminal illness or just terminal illness. I sometimes find it difficult myself. And so that is an issue. How do you assess that? The last thing they told us is we don't want any structural process. We're quite happy what we're doing. We don't need any screening tools or anything like that. It's not an important issue. So for me as a psychiatrist, I don't like hearing this because this is a serious assessment. We want to make sure the person doesn't have depression, because depression can also skew with that person's capacity. So when I talk about capacity as a safeguard. So we're going to take these results to Te Whatu Ora, the assisted dying service, in a couple of weeks and see how we can work together to improve the situation. So this is important research because they have direct clinical implication. I know the 10 people told us we don't want to change our process, but we may have to. I mean, do you want a change in process? Okay, lastly, these are about interviewing families. So this happened in the second year, and I talked to 15 families, members. 7 of them did not, their family member who died didn't use assisted dying. Some did, some considered, but ultimately didn't, so there were 6 of them. And then 2 actually used assisted dying. I'm not going to show you all the results, but I think just read the top, secrecy about assisted dying. People don't want to talk about it. I guess we're not very good at talking about death anyway, in general. But if it's assisted dying, and if I have a family member died by assisted dying, I don't want to tell other people. And then the family holding all this information themselves and not able to process the grief. Because part of grief is to express the grief and communicate that with your friends and family. So if you hold that as a secret and not able to process that, family get affected as well. So the next project, current project is looking at support group, how to support family, their loved one have died through assisted dying. Not just family, but another support group for practitioner that have gone through. Because I haven't told you, practitioner also say it's quite an emotionally charging experience for them. Because doctors, we're not taught how to we're pro-life. We're not taught how to end someone's life. So there's emotional issues there. So yeah, Ida's doing that. She has an HRC activation grant to run these groups. So you're going to be quite busy. Okay, I'm probably over time. So I'm going to talk about this. I'm going to the final slide. How about that? Okay, conclusion. I didn't talk about the last point, so ignore that. So still relatively new, end-of-life care in New Zealand, 3.5 years. And the experience of the health professional will continue to evolve. So it may be worth doing another study in 5 years' time, I don't know, to see what happens then. Are they going to tell us the same story? Maybe, maybe not. I asked that, do we need a more standardized way to assess depression? And yeah, a need to support both family and health professional. And I also mentioned we need to monitor the suicide statistics. We just don't know, it's an area we don't know whether assisted dying can reduce suicide rate. We don't know. International literature say it's equivocal. We're not sure. So an area we need to watch for. So thank you.
Right, well, we've got Gary up here. We've got 5 minutes for any questions. Yeah, and it's a difficult topic, isn't it, Gary? Yeah. So thank you for expressing it in the way you have. And
Do you want a mic here?
Yep, Mike. Here we go.
Are you aware of any figures showing a difference between assisted dying in isolated or more rural communities as compared with city communities, please?
Yes, I would say no. I'm not aware of any figures at the moment. Haven't looked into that. Yeah, that's a good research question for us to go away and have a look at that. The data is there. Yeah.
I do recall in the news media a commentary on that, but I just can't remember.
Yeah. Did I think it may be higher in rural areas?
I think it is access.
Okay,
again, yeah.
good point. Yeah.
There was a woman on a doctor
Yeah.
on radio. She has her own airplane and she flies all over the South Island
Ah.
to provide access.
Oh yeah. Would you like?
Sorry, the live stream won't be able to hear your comments.
Yeah.
I don't know the name of the doctor, but she's in fact she's quite senior in Doctors Association and stuff. But she flies her airplane across parts of rural New Zealand to provide access because she believes so strongly that people need access. So it's quite a challenge.
Yeah, and we'll. Yeah.
Can I just say, I worked previously at Waitamatta and I used to assist we're very few numbers that the hospital was asked to assist with. And I think it's interesting to have the observation, and I will just speak to because as chief nurse, I decided that my nurses felt really conflicted about participating. Yeah. But actually, my observation, and when I worked alongside the nurses in supporting the doctor who was often called to do it, it was the most beautiful experience for the family and to the client. They were really clear what they wanted, and it was done with beauty. Yes. I've never seen a more peaceful ending. And I probably would say there's about 8 times that I participated to support. I was only just there as a nurse to support. Yes. And it was done. What did find a challenge was the funeral directors. Yeah. No one had spoken to them about this, and so they were conflicted, but there was no support for them. Yes. So I think there's definitely a need for the support processes. And I know that I offered support to the doctors sometimes too, who sometimes felt just because there's such a small number of them and they have to fly all over New Zealand. Yes. I think the people that I experienced, they had the long-term conditions, you know, and they were really reaching the end of life, and they didn't want to be a burden. I think that was all. But the family were very upset, but still very supported.
Yes, yes. Thank you. The rural access is an issue. So under the Act, you need 2 practitioners to assess the person. If either of them have issues or questions about the person's capacity, they can refer to a psychiatrist. So I'm the psychiatrist list, but I've never seen a person because often they need someone to assess tomorrow. And I can't cancel my own clinic, and they live in rural areas, so rural access is an issue. Because of limited time, I didn't tell you all the other stories the practitioners have told us. I have heard a lot of stories about the satisfaction the practitioner got out of helping the person a peaceful death. So that go with what you've observed. Thank you.
Just one very quick question from me. Yep. So when you put up the slide that said 834 applications, but then only 370. Roughly. So is that because a lot of the applications weren't eligible?
Yeah, and some people also died before the days they set for assisted dying. Or they changed their mind maybe. Can
I just ask in relation to that, what is the average length of time from What's the average length of the time from an application to actually having assisted dying? Is this a week usually, or is it a, you know?
Ooh, 3 weeks? Thank you, Ida.
On the website, it says it should take around 6 weeks, but we've seen variation from it can be expedited if there is a sudden decline in health and the death is impending and they've been approved, so they can bring the date forward if that's the case. But we've seen like from week 10 days up to a couple of weeks, so it varies, depends on the situation and and resources and everything.
Yes, the person, we came across a person in our service and took him about three weeks. So it's variable, yeah.
Right, well, I think we better close it there. And thank you very much, Gary. That was really informative, and thank you for handling such a sensitive subject as well. So, a little round of applause for Gary. Thanks.